Satisfy your need for happiness through your own curiosity with the Ranveer Show. I want to talk about plaque again.
Okay.
So you're saying that the basis of it is a combination of genetic factors, lifestyle factors? That's about it?
Not as simple, but in the genetics, there's a couple of things. Why is it that some people are either predestined or have a very strong family history of heart disease, and other people can eat whatever they want and get away with it? You know, they talked about a Mediterranean diet. They talked about parts of France where they never got heart disease. As we're doing more and more studies, what we're finding, and there was an epic study on Crestor, which looked at cholesterol for 12 years. And Crestor is a drug which reduces cholesterol. And what they found was at the end of the 12 years, for primary prevention, so let me back up. At some point, if you had high cholesterol, everyone was on some type of anti-cholesterol medication. I don't want to use brands, but the point is HMG-CoA reductase is the broad category of what they were. And so what would happen is we would all go to maximum lipid lowering, thinking that that was what caused heart disease in everyone.
You mean lesser fat in food?
Lesser fat was the first thing. Then in addition to that, if you, on your physicals, when you hit 40, 50, whatever, they check your blood and the cholesterol's up, immediately everyone would go on a statin, right?
Go deeper into cholesterol, sir. Like, what is cholesterol? What is LDL, HDL? Just so that people get...
Yeah, so boy, this is going to get very technical fast. But and remember, I'm a cardiac surgeon, so the real experts are the cardiologists. But anyway, the way cholesterol works is it's used by your body to make hormones, estrogen, testosterone, all of that. It's also used in building blocks, right? But it's also, taken from fat and all the other stuff. Now, what happens is with cholesterol in its worst phase, when you get a tissue injury in the coronary arteries where the blood pressure's up, or you get scar forming, the first response is white cells go in, and then that area basically takes on cholesterol. As those tissues die, the plaques are actually tombstones of the cells, right? You know what a tombstone is, right? Yeah. So that's the calcium plaque. And so
the dead bodies of WBCs.
No, the dead body of those endothelial cells. Those endothelial cells are the lining of the artery.
Got it.
And so when they get damaged, to repair, the normal system is you'll get white platelets and white cells going in to repair that. But in patients who have high cholesterol, the cholesterol can also be deposited there in the right setting, right? The interesting part is, why don't everyone get it? Now, they talk about HDL, good cholesterol, and LDL, bad cholesterol. LDL and VLDL are very sticky, and they tend to stick to the arteries. HDL is a scavenger, and it will actually protect you. HDL goes up when you exercise. LDL, by comparison, will go up if you have the wrong sort of genetics, or alternatively, if you're eating a lot of high fat and whatnot. Is that a bad thing? So in patients who have documented risk factors for heart disease, a first degree relative who has had a heart attack or died of heart disease, and in particular, if they're less than 50, very high risk factor, 4 to 10-fold higher than baseline. Then you can look at diabetes. Diabetic patients are at a higher risk for heart disease. If the patient themselves have had a heart episode, a heart attack, or they have significant coronary artery disease, those guys have risk factors. Hypertension, high blood pressure is a silent killer, because you get very high pressures which cause injury to the arteries, and from that you can get cholesterol deposition. Smoking is an independent risk factor, which from the nicotine as well as the 2,000 other byproducts will increase your risk of heart disease and actually make it accelerate, right? So if you have these primary risk factors, then in that patient with a high cholesterol, you would put someone on a statin. On a statin, either a statin or another type of cholesterol reducing medication.
Okay.
And that you have to consult your local doctor, your cardiologist or your GP, because it needs to be monitored, and you got to make sure that you don't get complications. But in this Crestor study, what they showed is that primary prevention is not there unless you have primary risk factors for heart disease. So after that study, people kind of got a little more lax about cholesterol and said that it's not a single variable equation. There's multiple variables which are causing heart disease.
So that basically what that statement meant is that if you have high cholesterol levels in your bloodstream, it doesn't mean you're necessarily prone to heart disease.
That's right. In the context of someone with primary risk factors, the ones we mentioned, there you would definitely pay attention.
I'm still not completely clear on what causes the blockages. I understand it's scar tissue in a way, right?
Yeah.
As well as cholesterol that goes in deposits.
Yeah, and then so the way it works is that you'll have a injury to the endothelium from high blood pressure or just the heart pumping hard. That injury will be repaired by white cells to the endothelium. And during the process of that, if your cholesterol or lipids are high in the right patients, that lipid will go in. With the injury, sometimes the cell will die, and the calcium then, which gets deposited there, is what we call the plaque. Now, here's the tricky part, and when it becomes harmful, that plaque can then go on to rupture. And when it ruptures, let's say you have high blood pressure or you're exerting yourself and the narrowing in your artery. So two things can happen. One is as the plaque gets bigger and bigger, the lumen or the inside of that artery, the diameter gets smaller and smaller. And it becomes a flow issue. And, you know, at 75% blockage, you're blocking 90% of the flow to that artery. And that's when your muscle gets starved of blood flow. So that's one mechanism. The second one, which is more acute and where you see it in sudden death or even in heart attacks, is when that plaque ruptures and then you get a platelet plug. So the normal response to a rupture or an injury in an artery or a hand or anywhere, right, is that the endothelium, the inside of the artery, and then some of the other components are exposed, and there's naturally occurring elements in your blood, thrombin, antithrombin, and all these which get activated. And with that, platelets stick to it and they cause a clot, and that plugs up the hole. So in this case, when the plaque ruptures, you don't necessarily have a true hole, but if that plaque ruptures, then the platelets sticking to that can cause a clot, which completely blocks that artery. So now you went from a narrowing to a complete blockage. And when that happens, you get a catastrophic decrease in blood flow to the muscle affected. And with that, depending on what's with the muscle, if it's neurologic tissue like the conduction system, or if it's other tissues in that area, you get a heart attack.
Okay. With someone like yourself, you're 57, you're
Yeah.
very healthy, you take care of yourself. Is plaque still building up in your heart?
100%. And so let's qualify that, right? There are people who have gone to 80 and 90 and never have any plaques because for some reason, their body's system of scavenging and processing the lipids is such that they don't have a lot of sticky lipids, if you will. For whatever reason, those people don't have primary risk factors for heart disease, and you'll never see them having heart attacks. In others, right, in kind of, you know, the Indian subcontinent, there was a good study in 2003 which looked at young men, and this was a topic on my channel, that why are we seeing all these younger guys getting heart attacks? And for one thing, our LDL processing is aberrant in many cases genetically. And then the second part of that equation is stress is high, always, right? And then the third part of that equation is perhaps our arteries are smaller than our Nordic counterparts who are like 6'5" and burly, right? And so the combination of those things leads to narrowing much more prematurely. I think versus, I mean, this was described in 2003, 2004 in the annals, and I don't think that the incidence has gone up as much as us recognizing the incidence through our media and social media and other things. Every week I turn around and someone has succumbed to a heart attack or had a heart attack, right? It might be a driver, it might be a relative, might be someone you work with, whatnot. I'm hearing it way too often, and it's preventable potentially. So back to what you were asking, will I have plaques? Well, the interesting part is I do whole body scans, and I wouldn't necessarily recommend them as standard. In fact, I think about how you should get medicine is very focused to what your needs are. They should look at your medical history, your past, your family history, your social history, and look at what your risk factors are for disease, and then order any type of corroborative tests. And you know, when we were taught back in the 80s, in the 90s, when I was going through med school and whatnot, it was very clear that 80% of your diagnosis was made through history and physical, and 20% with corroborative testing. Now it's turned to a system where it's the tail wagging the dog, where we often get the studies first and then see our patients after that. Many reasons that occurs.
You mean that they do the test first and then understand
Yeah.
the past of the patient?
Yeah.
But it's important to know the past of the patient and then accordingly do the
because I think
tests.
that guides you. Alternately, you have these huge packages they now offer where they give you this battery of lab tests and, you know, whole body scans and this and that. Look, I don't think you should be exposed to radiation unless you need it or if there's a risk factor for it, right? Does it help knowing early? Maybe in a few cases. I mean, just as an aside, this you'll find interesting. In the 90s, CT scanners came on the scene. And back then, trying to get a CT scan, you had to book it a week in advance and crazy stuff. But what ended up happening is we would find a lot of incidentalomas. These were lumps and bumps and tissue which we thought might be worrisome. And we didn't know how to interpret the data. The same thing's happening now with these watches and other things. We get a lot of data, we don't know how to interpret it. What ended up happening as those incidentalomas came into being is a lot of patients went through relatively unnecessary surgery, and they had these things removed because we were worried that they might be a tumor, this, that, and the other. Come to find out that in most cases, that's not why people would pass away, right? And so the technology should not be dictating the treatment. It should be your clinical acumen, which should guide the technology, and that should be your corroboration.
If you enjoyed today's clip, make sure you check out these curated playlists that we've made especially for you related to the subject that was spoken about in this clip.